So we're going to talk a little bit about the SVP instrument. And just as a starting point, I think where we've all started is with this historic syndromic nomenclature that we've been stuck with for 30 or 40 years, whereby these three syndromes here, Meissner syndrome, typically associated with compression of the left common iliac vein and associated with lower extremity obstructive symptoms, the pelvic congestion syndrome, typically associated with chronic pelvic pain in women, and the so-called nutcracker syndrome due to left renal vein compression associated with renal symptoms of flank pain and hematuria. But this really doesn't serve us very well in caring for these patients, in that both common iliac compression and left renal vein compression can also cause chronic pelvic pain. This scheme doesn't account for varicocele at all in men who may have left renal vein compression. And any of these three may cause pelvic origin extrapelvic varices in the vulva or in the posterior medial thigh. And this has led to a lot of confusion, diagnostic uncertainty, and very limited research ability if we're grouping all of these patients together and expecting a left common iliac stent to treat primary ovarian vein incompetence. So we really need a more logical classification system. And part of the reason why it's hard to make sense of this is that when we look at the spectrum of pelvic venous disorders, we see that similar symptoms can arise from different underlying pathophysiology, while the same pathophysiology can lead to different symptoms in different patients. And this has to do with this hemodynamic concept that was originally described for the left renal vein of compensated versus uncompensated hemodynamics, where in uncompensated hemodynamics, increased venous pressure due to either reflux or obstruction is transmitted to the immediately upstream flow being towards the heart venous reservoir, while if it's compensated by collaterals, it may not be transmitted to the immediately upstream venous bed, but be transmitted more distally via collaterals to these other beds. And in this fashion, we can see that although chronic pelvic pain is classically associated with left ovarian or left internal iliac vein reflux, if there's primary renal vein compression with secondary ovarian vein reflux or primary common iliac vein compression with secondary internal iliac reflux, we can also get pelvic symptoms. So different underlying pathophysiology leading to similar symptoms. We can also have the case, though, where the same pathophysiology, for example, a left renal vein compression, can lead to different symptoms. In uncompensated obstruction, that is pressure transmitted directly to the renal hilum, we get symptoms of flank pain and hematuria, while if it's compensated via reflux via the ovarian vein, we get pelvic pain. And that's why this syndromic nomenclature really doesn't work very well. And with this in mind, the American Venous and Lymphatic Society in 2018, in conjunction with a number of other multidisciplinary international societies, set out to create a new discriminative instrument meaning not a severity score, but puts patients into bins with similar clinical features and outcomes with the goal of creating this instrument. The resulting instrument was the SVP classification, standing for symptoms, varices, and pathophysiology, which is organized very similar to SEEP, and both of these were published both in Phlebology and in the Journal of Vascular Surgery in 2021, and I hope everyone will read this after attending this session if you haven't already. So essentially, this is where the SVP classification differs from SEEP. Those of us who use the SEEP classification know that it's very sign-driven, things like skin changes, edema, ulceration. This is very patient-centric and very symptom-driven. And the whole classification starts with the patient's symptoms. And pelvic venous disorders are generally associated with four broad groups of symptoms: renal symptoms of flank pain and hematuria, chronic pelvic pain in men and women, pelvic origin extrapelvic varices in either the vulva or the posterior medial thigh or along the sciatic nerve, as well as lower extremity symptoms where pelvic varices may communicate directly with the great saphenous vein or the small saphenous vein, as well as symptoms of venous claudication. So symptoms is the first component. Then we look at what variceal reservoir is involved. And these reservoirs is where increased venous pressure due to either venous reflux or obstruction is transmitted, and it's where varices occur. And the four venous reservoirs are the renal hilum from left renal vein compression, the venous plexuses of the pelvis, the transitional veins which exit the pelvic floor through the pelvic escape points to the lower extremities, and lastly, the lower extremities themselves. And these result from two patterns of reflux, either in the left ovarian or the internal iliac vein, or obstruction either of the common iliac or renal veins here. So if we look at the SVP instrument in this sort of light, there's three primary domains. There's symptoms, there's the involved variceal reservoirs, that is where varices occur, and then there's the pathophysiology. And the pathophysiology has three subdomains that are exactly analogous to use SEEP. This seems complicated, but if you use SEEP, it's organized in the same fashion. There's the precise anatomic segment involved, the underlying hemodynamic abnormalities, that is whether due to reflux or obstruction, and the underlying etiology. And each of these is written as a subscript to SV and P with all of the hemodynamic abnormalities A, H, and E under pathophysiology. So in talking about symptoms and varices, this is based upon dividing the pelvis into the pelvic circulation, which includes some of the abdominal circulation, into 4 zones. And these 4 zones are based on 2 things. Number 1, the primary drainage pathway for that zone, and number 2, where the venous reservoir or the variceal bed is in that zone. So the first zone is associated with symptoms of flank pain and hematuria. Primary drainage is the left renal vein, and if there are any varices present, they will be in the renal hilum, which are often difficult to demonstrate with standard venography, but they usually can be demonstrated if you try hard enough. Zone 2 is the pelvis, drained primarily by the ovarian and the internal iliac veins. Symptoms are related to the pelvic venous plexus, which is where varices occur, and a chronic pelvic pain. Zone 3 is those transitional veins exiting the pelvis. They're associated with vulvar scrotal veins, as well as venous claudication, because in the end, you're transmitting venous pressure downstream to the leg. And the 4th reservoir is the leg, which is better described with SEEP than with SVP. As far as the pathophysiology goes, there's a precise anatomic definition which follows the same conventions as SEEP. If you use SEEP, this follows very similar conventions. The underlying hemodynamics, whether reflux or obstruction, and the underlying etiology, whether non-thrombotic, thrombotic, or congenital. And this is organized as pathophysiology, anatomy, hemodynamics, E, so that it reads exactly like a sentence. For example, P, left common iliac vein, reflux or obstruction, non-thrombotic, is read as non-thrombotic left common iliac obstruction, as shown here. So to give you an example of the utility, we don't have time to go through all of this in detail. If we consider that primary ovarian vein reflux, primary left renal vein compression with secondary reflux, or primary common iliac vein compression with secondary internal iliac vein reflux can all cause chronic pelvic pain. So it really makes no sense to refer these to these as pelvic congestion syndrome. If we use the SVP classification, all of these have pelvic symptoms, that is zone 2, so they're all S2. They all have varices in the pelvis, zone 2, V2. However, with the renal vein compression, you also may have varices in the renal hilum, so it's a V1-2, but the pathophysiology is very different, ranging from bilateral gonadal vein reflux to left common iliac vein obstruction, helps to sort these out. This is confusing on the first time through, but I think it's important to recognize that people said that about SEEP for 15 years before it was adopted. There are several things you can do to help with this. There is a workshop tomorrow at 10:30 where we'll go through SVP and particular cases. There is also, the workbook is available online on the AVLS website, and there also is an app that Kathy Gibson is going to be presenting the initial results from that later on this week that aids in this classification. So in conclusion, these are complex disorders related to what we talked about, this compensated versus uncompensated hemodynamics, and the fact that similar clinical presentations can have different underlying pathophysiology, while the same pathophysiology can lead to different clinical presentations. The historical nomenclature needs to be abandoned. It is misleading. The SVP instrument is complex, but I think it's important to recognize people said exactly the same thing about SEEP, which is now the most commonly used instrument for lower extremity venous disease in the world. Do read and reread the manuscript, come to the workshop, and use the app to help you in patient care. Thank you very much.